So it's my pleasure today to introduce Dr. Jonathan Meyer. He's going to be speaking to us today about recent advances in diagnosis and management of XY DSD. He's an assistant professor in the Department of Pediatrics, section of Diabetes and Endocrinology, OU, and a member of the Harold Ham Diabetes Center. He went to medical school at UTMB Galveston and did his residency at the University of Texas in San Antonio, and then finished fellowship in OU several years ago. He has specific interests in congenital adrenal hyperplasia and differences of sexual development, or DSD. He does a multidisciplinary clinic called Succeed to care for complex patients, and is also working on focusing on improving surveillance and treatment for CH and DSD. He's also involved in newborn screening as well. So I'm very happy to have you join us virtually. Look forward to having you in person, and we'll go ahead and go forward from there. I think, do you want to try again to see if you can present your screen, or if not, we'll just go ahead and move forward with your current view.
Yeah, let me try one more time.
Okay. Try maybe slideshow and see if that'll work at the top.
I'm assuming that's the wrong one.
Yeah. Let's have our AV person work with you and see if they can get it.
So we're seeing right now, we're seeing the correct view on this side. You're seeing the incorrect view on that side, sir?
No, we need to remove this note. So we need to hit the high.
Oh, yeah. Just go to the top where it says display settings.
We can't access that. So that right. Is that right there?
Mine doesn't have that, I don't think.
Okay, go ahead and hit escape. All right, now, so the goal here is that you need presenter view, correct?
Right.
All right, so maybe stop your screen share first. Okay, now go back to your PowerPoint and put it into presentation mode. And then Alt-Tab over to Zoom and do your screen share again, this time selecting the full screen view for the screen share.
Okay, does that look right?
We don't have it just yet. Did you do the screen share again? So Alt-Tab back to Zoom. And once you're in Zoom, at the bottom, screen share. Cool. Now we have it looks good on this side. How does it look?
Yeah, it's just the wrong window. I always have trouble figuring out on mine. So maybe I have a weird version or something. So, okay. Well, thank you very much.
So are you good? You're good now? Cool.
I think we're good. So thank you, Dr. Seelman, for the introduction. I'm very, very pleased to be here today. I just want to thank the rest of the PESTOLA Planning Committee as well. I know I've talked with Basita and Daphne extensively, and thanks for all your help. Thank you for Dell Children's as well for hosting this event. I know there's been a lot of obstacles to get through. As Dr. Seelman mentioned, I want to talk about XY DSD today, and I'm hoping that everyone can learn a few things. I have no disclosures. And so today I'd like to talk about really basic XY-DSD physiology and pathology. We want to talk about current diagnostic methods in XY-DSD. I want to talk about when we should probably pursue a genetic evaluation. And then look at diagnosis and management of two of the more important genetic mutations in XY-DSD, and kind of summarize this with a few cases pertaining to these diagnoses. So I'll start with the interesting case from a few years back. This is a patient, a 23-month-old male, who initially presented to clinic with ambiguous genitalia. He was adopted from China with really little known about his birth history. And so on exam, there are bilateral, palpable, and distended testes. There was perineal hypospadias with chordee, and micropenis was seen on multiple examinations between 1.5 and 2 centimeters. Workup included karyotype that was 46XY. An HCG stem test was done at the time. Androstenedione stemmed to 11. Testosterone stemmed to 160 nanograms per deciliter. And dihydrotestosterone, or DHT, stemmed to 26. So this is suggestive of some testicular function. An ultrasound was done prior to our first visit, actually done in China, reported undescended testes, and there was no clear female internal anatomy. So not complete information, but knowing what you have, I want you guys to think about how you would diagnose this patient, or what sort of diagnosis you would give to this patient. Now, a second case, we have a 9-week-old female infant that referred to our clinic for what was called XY-DSD. This is a very interesting case in the sense that this is one of 2 twins that were both born as females. And family only performed allele testing, which I haven't seen all that often, and they really only want to see if they're identical or fraternal twins. Allele testing showed XY twice on one of the twins, and this is done via buccal swab in both occasions. So when they were seen by me initially, there was very clear female external anatomy with no palpable testes. And labs and imaging showed a repeat karyotype that was 46XY. LH is 1.5, FSH was 15.3, AMH, or anti-Mullerian hormone, was undetectable, and testosterone was less than 10 nanograms per deciliter. This was done during the prime time for mini puberty, and so this is strongly suggestive of hypogonadism. A pelvic ultrasound was done that showed a possible rudimentary uterus. Homogeneous soft tissue nodules were seen in the bilateral lower quadrants, which had the appearance of testes. And so again, as per the previous discussion, what sort of diagnosis would you give to this patient, or what are you thinking right now? And so let's talk about DSD a little bit more. And before I really talk about DSD, I want to talk about the terminology as well. When I started my training, DSD stood for really disorders of sex development. Over time, differences has probably become the slightly preferred term, although disorders is still used quite a bit. Of course, both of them would be DSD. In addition, intersex kind of fell out of favor many years ago, and it seems like it's coming back as well. So these, to some extent, are interchangeable terms, although I'm sure there's going to be more discussions over the next several years about this. But within this field, we'll talk about DSD going forward for the rest of the presentation. This is something we've seen about 1 in every 4,000 infants. And so one of the best definitions I've seen is chromosomal, genetic, gonadal, hormonal, or anatomic aspects of sex that are atypical. Another terminology, we classically pick this up via ambiguous genitalia, usually in a newborn or a small child. Atypical is probably also slowly becoming the preferred term, although certainly both are used extensively in the literature. We usually define this as at least 2 of the following things: micropenis, hypospadias, undescended testes, clitoromegaly, or labial fusion. And so workup for DSDs includes a thorough physical exam, oftentimes labs, and imaging of the internal structures. These patients are typically seen in multidisciplinary teams. This is really the standard of care. There's been, of course, many articles about this, and that's certainly what we try to do. And I want to talk about specifically XY-DSD. I feel like this poses a lot of diagnostic and therapeutic dilemmas. I think it's incredibly interesting in how far we've come in the field. And so for the rest of the presentation, I'll mostly focus on XY-DSD. And so for those of you that are somewhat unfamiliar with DSD, I know we have a lot of trainees in here as well. I'll kind of start with some of the basics. And so we've thought of DSDs, in terms of normal sexual development. The physiology really involves 3 processes: development of gonads, internal anatomy, and external anatomy. And so the gonads are probably the most straightforward. We think classically that an XY fetus will develop testes, an XX fetus will eventually develop ovaries. The internal anatomy is a little bit more complex. Initially, all fetuses have both Müllerian ducts and Wolffian ducts, and these are the undifferentiated early structures. And so in a 46XY fetus, we have the SRY gene on the Y chromosome, we have SRY produced, and we have formation of testes. These produce testosterone from the Leydig cells, and they also produce anti-Müllerian hormone from the Sertoli cells. And as a result, we have testosterone supporting the Wolffian ducts. These ducts become the prostate, the vas deferens, the seminal vesicles, and epididymis. And the AMH causes regression of the Müllerian ducts. So we are left with reinforced male internal structures. Now, in a 46XX fetus, we do not have a Y chromosome. We do not have SRY produced. We have ovaries, and so as a result, we have no testosterone and no AMH. And so as a result, we have no testosterone to support the Wolffian ducts, and there's no AMH to aid in the regression of the Müllerian ducts. So these develop and become the uterus, the fallopian tubes, the cervix, and the upper portion of the vagina. External anatomy is the third part of the puzzle. And again, testosterone is very important with this. It's converted to DHT via 5-alpha reductase. Most of the time we consider with no testosterone, we have no DHT, and we have female external anatomy. And on the other hand, if we have testosterone, we hopefully are converting appropriately to DHT, and we have male external anatomy. Here's a kind of presentation of sort of what happens during this process. On the right here, you have a picture from Netter showing the undifferentiated structures that can kind of go either male or female, depending on the amounts of testosterone and DHT involved. On the left here, these are the sort of undifferentiated structures specifically. You have the urethral folds that become either the corpus spongiosum and penile urethra in males, or the labia minora in females. The labioscrotal swelling becomes either the scrotum or the labia majora, and the genital tubercle becomes either the corpora cavernosa or the clitoris. So this is all assuming everything goes right during development. Of course, there's a lot of steps in this process. There's a lot of places where things could, quote unquote, go wrong. And so classically, we sort of thought of, first of all, we need to have appropriate, X and Y chromosome 46XY, so we have some sex chromosome anomalies. We need to have appropriate testicular formation. If not, we classically call this gonadal dysgenesis. The testes need to produce testosterone. There are, of course, gonadal or adrenal enzyme deficiencies that can cause poor testosterone production. We need 5-alpha reductase to get to dihydrotestosterone. And then, of course, we need a working androgen receptor. Otherwise, we can have androgen insensitivity syndrome. If all these things are working well, we finally get to really what we call normal male external genitalia. In addition, the testes need to be working properly, especially the Sertoli cells, to have proper production of AMH and Müllerian regression. So classically, we've tried to work this up hormonally, and we include AMH, gonadotropins, testosterone, dihydrotestosterone, and then oftentimes a pelvic ultrasound, and then possible targeted gene testing. As we can see here, the first few steps are very much sex chromosome or phenotypic diagnoses, whereas we do have a few targeted genes at the bottom of this pathway here. Now, over the last several years, medicine has evolved, and we found out there's a lot more to the first few steps than maybe we knew about or thought many years ago. So we know that there's issues potentially with the early mesoderm, so kind of the priming of the gonads. There could be issues with differentiation of the bipotential gonad into a testis, and then there's potential issues with differentiation of the Leydig and the Sertoli cells. And so just to keep it simple, what we found out is there are a lot of genes, a lot of transcription factors associated with these issues. Some of the main ones that we know about are WT1, NR5A1, SRY, but there's many, many others. In addition, if we think about a way to test for all these, particularly maybe at one time, we of course can include some other genetic tests, maybe for instance, androgen receptor, 5-alpha reductase, as well as AMH or AMH receptor. And so the question is, how do we actually do these tests? And so we have a lot of information about this after some of the lectures yesterday. So many of you are now familiar with next generation sequencing, but I will say a few more things about that as well. So next generation sequencing is named to differentiate it from previous testing, such as Sanger sequencing. We're looking at single genes. So this is a way of testing, also called massively parallel sequencing or high throughput sequencing that tests many genes at once. The first one I want to talk about is exome slice. And so this is probably the one that's run the most. This is basically looking at many genes in a panel. Many panels now run 100 or more genes potentially, but of course you can always choose a custom panel that may be, only like 10 or 20 genes, or it can be up to hundreds of genes depending on what you want to do. And this looks at the exons of the genes of interest, as well as some introns that are very close to exons as well. So it's mostly exons with a few introns. Whole exome sequencing is sort of the next step, and that looks at really all of the exons in the genome. And of course, this is going to be a little bit more involved than the exome slice. Whole genome sequencing is almost never done, but this is something that is theoretically out there that's looking at essentially the whole genome, as the name implies. Besides the possible diagnostic yield, another nice thing about these tests is that a lot of times the recommendation is to, once the test is done, potentially repeat the test another 1 to 2 years as more and more is available in the literature. And so this is oftentimes, depending on the company, done free of charge for the patient. Maybe it's like a one-time thing. And then in rare circumstances, depending on who you run these tests through, they may actually find some stuff with their own internal database. And we actually had an example recently where a company reached out to me to actually rerun a sample where they may have found a new mutation. And so I'm actually waiting on that result over the next probably few weeks or so. Now, there are certainly some drawbacks to all these as well. One of the biggest drawbacks is going to be for the whole exome sequencing and whole genome sequencing is the possibility of secondary findings and disclosure. As discussed yesterday, this can certainly be a problem. You need to have a plan in place for what you're going to do if you find out results that you don't necessarily want to find out about or kind of find out about in terms of cancer risk and things like that. And so this almost certainly should be discussed with genetics, and informed consent is an absolute must in these cases. There's also a problem with variants of unknown significance. Again, this was discussed in depth yesterday with Dr. Gibson. This is something that we struggle with on a routine basis, but of course, I know we do the best we can to sort of figure out what's going on. And then the cost could be prohibitive as well. This has gotten a lot cheaper over the last many years, but still out of pocket is oftentimes $2,000 or $3,000. Thankfully, insurance does pick up the cost in a lot of cases, but it's not, of course, 100% the case. And so in the field of DSD, we've come a long way. This started to kind of show up in probably the early 2010s or so. And by sort of the mid-decade, we started to have really big papers on this. And this is one of the first big ones that I came across. This is from the group in Australia, led by Eggers and Sinclair, looking at genetic testing, exome slice in a large panel of DSD patients. And so this came out in 2016. At the time, they posited about 13% of patients receive an accurate clinical diagnosis, which is fairly low. They looked at 278 patients with XY-DSD, another 48 with XX-DSD. So it's a pretty comprehensive study. And they developed a massively parallel sequencing targeted gene panel to sequence 64 known diagnostic DSD genes. During the study, they found 93 previously unreported variants, which is obviously quite a few extra variants that are now known in the literature. And so their results show that they really had likely genetic diagnosis in about 43% of patients with XYDSD. So this went up considerably from the 13% they talked about early in their paper. Now, so that's great. We clearly have an increased yield, but what about, how far should we go? Do you want to go and even take it a step further? And how much yield can we actually get if we think about doing things like WES? And so this is a paper that came out in 2020 from the Kansas City group. I know Kansas City sometimes is here for this conference, so I don't know if anyone is here today, but kind of interesting paper where they looked at a tiered approach to genetic testing. This is from 2008 to 2016. And so they went in stepwise manner. They did karyotype, individual gene testing, microarray, exome slice, and then WES plus or minus duplication or deletion studies. And so in their total study, they saw 60 patients. Out of the 60 patients, 28 underwent all available testing, and 18 of those achieved a molecular diagnosis, about 64%. However, as you can see here, this is only 28, and there are some perils associated with this, as to be expected. There are, of course, patients that were opting to not pursue further tests. They thought it was just too extreme to keep going back to the office to get more things done. And then, of course, insurance denied some of the tests, including, I suspect, the slice and WES specifically. I think were probably some of the big hiccups here. So even though, so there are certainly pros and cons to kind of going to taking these next steps with testing, but there certainly can potentially be an increased yield. And I think as we advance medicine, we're going to see more and more testing done and probably higher and higher yields. So maybe I think it sounds like we're oftentimes well over 50% in terms of diagnosing XYDSD at this point. Now, what's interesting is that some people are taking this even further. And so there's an interesting article that I found looking at doing this in prenatal testing now. This is definitely not standard of care, but it's something that I guess we're going to learn more about in the upcoming years. So when do we actually want to test? So we know there's certainly pros and cons to testing, as I've previously discussed. And so I think most of us would agree that if we have true discordance between, say, chromosomes, internal anatomy, external anatomy, those are patients we probably do want to test. But what if we have patients that are kind of typically classified as sort of our isolated anatomic anomalies, for instance? And so more specifically, the things I would think about when I hear that term would be maybe isolated cryptoorganism, biped scrotum, or hypospadias. And so this is, I think it's unclear how far we should pursue testing on these patients. And so I tried to look at some of the data the best I could on these specific patients. So we'll start with cryptoorganism. We have isolated undescended testes in 1% of males. So this is not uncommon. And so I think we've classically thought about this as maybe not like a huge deal, but something that, of course, we want to see potentially if we need to, and certainly refer to urology to address it if need be. When we look at the testing that has been done for cryptoorganism, we know that ion SL3 and RXFP2 are important for the transabdominal phase of descent, or the first phase of descent. And so these are found in 2 to 4% of boys with cryptoorganism, respectively. The second phase of descent is mediated by androgens. There's no question about that. And then we know that there are some AR mutations that can cause isolated cryptoorganism, but it's really not that common based on some of the studies that we've seen. There are many candidate genes associated with the second stage of descent. These do include WT1 and NR5A1, but really these studies have shown that this is more in animals and in vitro studies. There's really not a lot of human studies that have been done on this. So although there's certainly speculation to how important it is to be testing for some of these things with only undescended testes, I think the data is pretty unclear, and there's probably not quite enough data to be testing for this routinely, especially considering that, again, this is, 1 or more % of the population. Now, next thing I want to talk about is bifid scrotum. This is going to be a midline cleft in the scrotum that's often caused by incomplete diffusion of the labioscrotal folds. This is the most common scrotal anomaly, and it's oftentimes associated with hypospadias and corti. On the left here, I thought this is a more interesting way to present it kind of visually, but you can see here that this is a problem that is not just for today. It's been a problem for many, many years, where we have a terracotta showing that there are essentially, basically, looks like half of a scrotum on both sides with testes. And so the Boston group looked at this several years back. So Schwartzman, their urologist, looked at undervirilized patients with bifid scrotum and hypospadias. Unfortunately, as you're going to see in just a second here, isolated bifid scrotum is actually pretty rare. There's not all that much literature on that specifically. In this study, there were 110 patients from 93 to 2015. Within the total cohort, about 86% had severe hypospadias and 9% had either distal or no hypospadias. If we look at just the patients with GU anomalies instead of patients including syndromic patients, the number is actually higher, and there are only like maybe 2 patients without associated hypospadias, and then unfortunately there was no discussion on those specific patients in the study. Out of all these patients, genetic testing was performed on 70 or 64% of them. Out of those patients, 23% received a genetic diagnosis. This was mostly karyotype, some arrays, and things like that. But they did do autosomal recessive, AR testing, androgen receptor testing on these patients as well. On about 10 patients, 2 of them did have AR mutations. In a separate study, actually by the same group published the same year, they looked at another 10 patients with bifid scrotum. Again, all of them had associated hypospadias. And they looked at NR5A1 specifically, and 2 of those patients had NR5A1 mutations. Now, this is before the era of WS and WGS, so there's really none of this done. In fact, I don't even think there's exome slice done in this study. And so it does look like in some settings, AR and NR5A1 mutations are associated with bifid scrotum, but again, it's very hard to say specifically because there's just not that many. There's much literature out there looking at just bifid scrotum. It looks like almost all of it is associated with hypospadias as well. So we'll move on to hypospadias then. And so I just want to kind of talk about some terminology first. This is a picture from the CDC, kind of showing some potential clinical presentations of hypospadias. And there's obviously a spectrum. You can have subcoronal, midshaft, or penoscrotal. You can even have scrotal or perineal, which would be at the very extreme end of it. But when we think of hypospadias, again, sort of a subcoronal would be more anterior, distal, which would be mild. So these are all sort of interchangeable terms. Penoscrotal is essentially considered a posterior, proximal, or a severe hypospadias. And so we think of hypospadias occurring in, depending on what you read, 1 in 200 to 300 males. A decent amount, 10 to 30%, have a clear genetic cause. And so there's, and these are mostly anterior cases, so mild cases, but there's a decent amount that are severe as well. Many pathways have been implicated in the growth of the genital tubercle, and which is one of the things we worry about with hypospadias. This includes DHH, WNT, FGF, and WT1. Sort of the next step, as I laid out several slides ago, in terms of normal development of a male, include actual testes development. And so we know that genes like SRY, NR5A1, and MAMLD mutation, those are associated with hypospadias as well. And then, of course, the next step, as I discussed, is decreased androgen production. And so there's several genes that are associated with CAH, and then there's also AKR1C3 and HSD17B3. These are all genes that are regularly done on an XY DSD panel. And so we know that there's probably some association with these genes and DSD with hypospadias. And it's sort of implicit in this conversation, but I do want to kind of say explicitly that there's at least some data to suggest that severe hypospadias is more associated with gene mutations, although I don't think this is 100% the case with specific mutations. So another study that tried to look at isolated hypospadias, in other words, because we know there's oftentimes undescended testes, they're trying to look at mostly descended testes in this study by Rowe et al. And so this is a retrospective study from 2010 to 2016. And so within the study, we had 112 total patients. 91 had descended testes. There were 21 with undescended testes. So on the whole, 33% were tested for gene mutations. And so within these tested, while with the undescended testes, 33% had a genetic mutation. 10% of the ones with descended testes had a genetic mutation. Now, looking further at the data, most of these were syndromic patients. In other words, they had other genetic causes, not just isolated GU anomalies, which sort of skews the data a bit. But there were several that had VUSs that corresponded to genes associated with DSDs. So the authors concluded that although descended testes reduce the risk of DSD, they do recommend genetic testing for all patients with proximal hypospadias. And again, these are all patients with proximal hypospadias. Now, I'm not sure if that was necessarily clear because there weren't all that many patients that actually had a sort of DSD diagnosis or possibility in that study. But there's another case report that really kind of opened my eyes a little bit and kind of surprised me. They came out around the same time. And this is from the Chicago group, where they looked at a case report of proximal hypospadias, penis girdle transposition, and bilateral descended testes in an infant. And so the way they present the paper is they did the initial workup, hormone workup, as well as karyotype, and they didn't really find anything. And so even though they suggested that maybe there weren't all that many patients with isolated hypospadias with DSD, they went ahead and proceeded with a 62 gene exome slice. Lo and behold, they found a heterozygous WT1 variant in exon 1. This is previously unreported, so at the time they weren't sure if this was meaningful or not. But then at 5 months of life, this patient had an ultrasound, and there were lesions that were eventually shown to be a Wilms tumor. So obviously, nice they picked this up early. So the authors of this paper look at some other studies. There's some other scattered reports out there of isolated hypospadias and mutations, including WT1. And so genetic testing, they say that genetic testing should be strongly considered in these patients. So I'll finish up by kind of asking, well, why do we want to test routinely? So we obviously want to acquire medical knowledge about a rare condition. We already talked about 1 in maybe 4,000 infants or so. There is not that much data out there, which is kind of the exciting thing about this field to some extent. But it also means that we have to be cognizant about our tests as well. We want to provide answers for parents and families, kind of what's going on. And then really probably more than anything, we want to prevent and treat any associated comorbidities. And so one of the things that we always want to think about is cancer risk. We want to prevent cancer if we can help it. With some of these conditions, including NR5A1, we think about adrenal insufficiency. We worry about fertility in these patients, of course. And then there's always the psychosocial concerns, which have certainly been a big hot topic recently. In these patients of more specific diagnosis, rather than, say, sex chromosome abnormality or gonadal dysgenesis may help in these areas as we acquire more data. And so I want to start off talking about WT1. One of my more recent WT1 patients actually came to me, so it got me thinking about this in a little bit interesting way. They were actually diagnosed with a Wilms tumor first, got the genetic testing, and then were sent to me to kind of follow up. And so initially I was trying to think, well, what can I offer this patient? And so look at the literature a little bit on WT1. One of the things I started to think about and worry about is, well, is there an increased risk for gonadal which we oftentimes also see in WT1 mutations? And then there also can be a risk of the Wilms tumor itself metastasizing to the testes. So I think there are some things that we need to be worried about with WT1 in that specific patient. And so we'll talk a little bit more about WT1 right now. This is the Wilms tumor suppressor gene. It's located on chromosome 11. And we classically think of this as a spectrum of features involving genital and renal anomalies. There's obviously concern, as I mentioned, for Wilms tumor and gonadal. So other syndromes associated with this classically include Dennis-Drash, Fraser, and then WAGR. And this is really looking at this point, we think of it as more of a phenotypic spectrum, but it's partially associated with where mutations are. This is a rare cause of isolated hypospadias, and it's usually associated with cryptoorganism. And so these are something, again, often we talked about isolated hypospadias, but oftentimes these are associated with undescended testes. That is different than, of course, the last case report that I just brought up. So WT1 exon mutations are associated with Wilms tumor and a majority of patients with bilateral Wilms tumor. So if you have bilateral Wilms tumor, almost certainly have an exon mutation. These are the highest risk in truncating variants. So ARIA also looked recently at some other patients with WT1, and they found that the prevalence of WT1 among the whole population is about 3%. All these patients, again, had cryptoorganism. The authors note that exonic variants tend to be associated with Wilms tumor, while intronic variants tend to be associated with gonadal, which can be, of course, very helpful when you're looking at risk, again, for your tumors. And then they point out that there are actually 8 exonic variants that are also tend to be associated with gonadal. The most common out of these is actually the P arginine to 462 mutation. And then gonadal as early as 6 months of age was described in the study. And so this is something that we certainly don't want to mess around with. And so really for patients at risk, or we consider at risk, we really need to have some idea of how the testes are developing. And so making sure that they're brought down appropriately so they can be evaluated or have other measures in place. This article recommends probably checking them at least every 6 months or so. And the last one I want to talk about is NR5A1, which you all probably suspected based on the rest of my presentation. This is a nuclear receptor subfamily 5. It's on chromosome 9 and encodes steroidogenic factor 1 or SF1. So it's first expressed in the urogenital ridge and it drives testicular differentiation. It's further expressed in both Sertoli and Leydig cells to help regulate AMH and androgen production. And so Fabrice Gallet in 2019, their group read a pretty nice article looking at 205 cases. Out of all these cases, about 12% of XY-DSD patients had variations in NR5A1. So again, this is actually not maybe all that uncommon within the XY-DSD population. What's interesting about this, well, there's a few things actually. So almost all these cases are heterozygous. And so if you actually get a mutation on one allele, it probably is causative or at least playing a role in what's going on. The other 3% are smattering of either compound heterozygous or homozygous mutations. And Another thing that's very interesting that I learned was that the risk of adrenal insufficiency is really pretty low. There was, I think they measured this in about 175 of the patients in the study. 10 of them had adrenal insufficiency, and even within those 10 patients, several of them were very mild or borderline. And so because of the common gonadal and adrenal origins, we've always thought that this could certainly play a role in adrenal insufficiency, and it has certainly been described. But if patient looks pretty well on the whole, the risk of adrenal insufficiency is probably pretty low. And then overall, this article makes the case that there is a wide phenotypic spectrum. There's also not a clear correlation between genotype and phenotype. But if we do try to pin it down to sort of to phenotype, partial gonadal dysgenesis is going to be by far the largest proportion. Complete gonadal dysgenesis is another probably 10 to 12% of these patients. And so between the two of them, we're looking at about 80% of this patient population. And then another very interesting study from the past year is looking at 46 XY patients with an NR5A1 mutation, and it looked at them sort of longitudinally and kind of followed them through puberty. So these are a small study, 10 patients, and some of them were diagnosed, of course, late, which is why they're sometimes able to be followed up for this long. And they want to look at sort of, do they go through puberty and sort of what sort of pubertal development have they had? And so several patients in this study, most of them were sort of raised as females initially, showed spontaneous virilization at the time of puberty, often despite smaller testicular volume. The testicular volume in this case was sort of like a Klinefelter picture where the testes would grow to some extent and kind of level off over time. So a lot of patients in the study with apparently female genitalia presented with signs of virilization or at the minimum absence of female puberty. And so so there were some changes noted during puberty. This could be things like clitoromegaly that got worse or hair growth or things like that. Now, within these 10 patients, 4 patients actually had gonadectomy. 3 patients had histology available from the gonads. There was no malignancy associated with any of these 3 patients. All of them had gonadectomy between the ages of 15 and 17. And furthermore, this study cited a second study where there's a case report of 2 other teenage patients who had gonadectomy. One of them did have carcinoma in situ at age 13. The other one had no signs of malignancy. So the cancer risk may be a little bit lower than we previously thought. If we think of most of these patients in terms of XY DSD population have partial or complete gonadal dysgenesis, we previously thought as a long-term cancer risk is probably 30 or more %. But we will, of course, see how this develops over time as we get more and more data. And as I mentioned, adrenal insufficiency seems pretty low. In these 10 patients, there was no adrenal insufficiency that was noted. And so I'll go and start wrapping this up. Just to kind of summarize, DSD is an exciting and rapidly evolving field of endocrinology. And XY-DSD specifically is very complex. Diagnoses have classically been phenotypic in nature, but we're now supplementing that with increased ways to get our genetic diagnosis. We do that through next generation sequencing, and we of course add to the yield, but there are some significant drawbacks as well with these tests. Isolated biped scrotum and cryptoorganism likely due to some genetic etiology. There is going to be a lot more to come, I think, especially with cryptoorganism in the future. There's already some studies looking at that, but in terms of genetic testing and exome slice, I think that the yield is fairly low right now with these patients. Now, if we have proximal hypospadias in of itself, that one actually maybe should be tested because there have been some reports now of things like WT1. WT1 and NR5A specifically are becoming more common with genetic testing. And there's, of course, some significant implications of these findings. And both are, of course, associated with cancer, but new studies suggest that the risk of NR5A1 may actually be lower than previously thought. And WT1, you can predict cancer risk based on genetic mutation, maybe a little bit better than we previously thought. And of course, we need more information and more studies to continue to look at these things. So I will finish up with the two cases. I don't know if you guys thought about what you thought the diagnosis might be, but in case one, we did testing. This is a heterozygous mutation NR5A1 gene in exon 4. And in case two, this is also a heterozygous mutation NR5A1. This is actually an intron 5, so one of the rare cases where we have an intron mutation, classified as a VUS, but based on everything else that I've talked about, and of course the clinical presentation, it seems like it likely is related. And this just shows again the phenotypic range of NR5A1, which really is the main reason I wanted to do this. That really interested me to see how varied these presentations could be. I'll finish up very quickly by talking about our clinic. We have our multidisciplinary DSD clinic called our 6D clinic at OU. We see CAH, Klinefelter, and other DSD patients. If you have any questions for me, please reach out and contact me. My email and our office phone is here. I do want to thank our team at OU, some of which I'm sure are listening in right now, as well as my DSD mentors, Dr. Steve Chernusek and Amy Wisniewski.